Hi there, Corazon volunteer, and welcome to Charting 101. I'm Katherine Eichmann, the co-chair of Corazon Clinic, and in this video, I'll discuss how to properly document the medical encounter, which is an essential part of being a healthcare worker, whether you're a nurse, a physician, or a PA. I'll first explain the importance of charting, followed by reviewing the SOAP format, and lastly, we'll finish with a few examples. Feel free to take notes and jot down any questions you may have. So without further ado, let's get started. To start, well, what is a chart? A chart is a legal medical document that serves as a record for the medical encounter. If you've ever been to the doctor, you've probably seen loads of file cabinets with manila folders in them, or you may have noticed your doctor typing meticulously on a computer or on a laptop. These are both examples of medical charts. Essentially, a chart is just the record of each and every visit you make with your healthcare provider. Everything you discuss and everything the provider did is documented and recorded. Most charting is now done on a computer, which is called the Electronic Medical Record, or EMR, but prior to this, all charting was done on paper and kept in a file. At Corazon Clinic, we do things the old-fashioned way and document on paper. So why is charting important? Well, charting is important for many different reasons. First and foremost, it documents what happens every time the patient steps foot into the office. Everything that goes on in the visit is documented. The chart essentially provides a history of each patient, so you can view the chart almost as a history book. This not only helps you as the provider organize and document your thoughts over time, but it will also help other providers become familiar with the patient as well, which can help guide future medical decisions. I've heard that the difference between a good chart and a bad chart is the ability for someone else to read it and know exactly, or at least have a pretty good idea, of what happened during the visit, and what was done, and why it was done. As a healthcare provider, you'll see so many people a day, so cases blend into the next. So it's helpful to read past notes you wrote to refresh your memory on the case. Lastly, charting also provides legal protection for you and the patient in the case of malpractice claims. There's a saying that goes, if you didn't chart it, it didn't happen. And this is both true in the legal sense and also comes into play with insurance reimbursement, which charting is also very important for. So how do we chart? In most, if not all healthcare settings, the SOAP format is followed. A SOAP note is a way for healthcare workers to document the visit in a structured and organized way. It reminds clinicians of specific tasks while also providing a framework for evaluating the patient. The SOAP note helps guide clinicians as they use their clinical reasoning to assess, diagnose, and treat a patient based on the information provided by them. SOAP notes are an essential piece of information about the health status of the patient, as well as a communication document between health professionals. Many healthcare providers, ranging from physicians to behavioral healthcare professionals to even veterinarians, use the SOAP note format for all of their patients' visits. So let's dive into SOAP notes a little more. I'm sure you're wondering what SOAP stands for, so let's go over that. SOAP is an acronym. S for subjective, O for objective, A for assessment, and P for plan. The structure of SOAP documentation is basically a checklist that serves as an aid to retrieve information from the patient and process that information to help the patient, all while serving as a record for future providers who see the note. So again, SOAP is essentially a framework that stands for subjective, objective, assessment, and plan. But what do these headings mean? Well, let's go through each of these one by one. First, we have the subjective section. Subjective information is essentially documentation about what the patient says. Documentation should be about the experiences, personal views, or feelings of a patient or someone close to them. In other words, it's the patient side of the story. Subjective information provides context for the assessment and the plan, and also influences what objective data we'll collect. If we look at content, the subjective section includes the chief complaint, why the patient is here, the history of present illness, or HPI, the review of systems, or ROS, history including medical, surgical, social, and family history, along with current medications and allergies. I know this sounds like a lot, but don't worry. I'll break this down for you in the following slides. Second is the objective section. This section documents all objective data. Objective data is physical data that we can observe using our senses or through direct measurement. Objective findings come either in a measurement form or direct observation and cannot be argued or influenced by opinion or feelings. Examples of objective data include physical exam, vital signs, point-of-care tests, labs, and imaging. In other words, objective information is everything the healthcare provider is gathering from observation, such as the physical exam, and measurement, such as labs. Third is the assessment. This section documents the diagnosis. A diagnosis is made after analyzing the subjective information and the objective information. Sometimes a diagnosis can't be made that day. This normally occurs when there's a new complaint and further investigation is warranted, such as labs and imaging. When this occurs, a differential diagnosis can be provided. A differential diagnosis is a list of all of the possible diagnoses the patient may be presenting with, and usually the diagnoses in the differential are documented from most likely to least likely. The assessment section also includes an impression. The impression is a narrative that documents the thought process and decision-making behind the diagnosis. The impression is a great place for the differential diagnosis to be listed, along with your rationale. The impression is especially important for others who may read your chart so that they'll know and understand your thought processes. The fourth and final component of the SOAP note is the plan section. This section documents what is to be done as a result of the diagnosis, or what needs to be done to narrow down your differential and make a diagnosis. The plan section also addresses the need for additional testing, imaging, and consultation with other clinicians. It may also include the plan to prescribe medications, referral to another provider, or even in diet and lifestyle counseling. It's important to have a concise plan as it helps other healthcare providers who may read the chart understand what needs to be done next. In the next following slides, we'll break down each SOAP component. So before I explain the SOAP components in further detail, I wanted to show you an example of a chart. This is the exact SOAP note that we use at Corazon Clinic. The more you volunteer with us, the more familiar you'll become with this format. Starting at the top left, we have the clinic's information, followed underneath with the patient's demographics. We then have the chief complaint or reason for the visit. Underneath the chief complaint, we have the start of the subjective section, which is a space for the history of present illness or the HPI to be documented. If we jump to the top right box, we have some more subjective information, such as insurance status and allergies. There's also a box that pertains to the problem list or medical history. Also, please note the medical, social, and family history is documented on a separate sheet in the chart, so be sure to review that before seeing the patient. In the middle box, we have the objective section, which includes the physical exam. If we jump down to the box at the bottom left-hand side, we have the vitals. Again, these are both part of the objective section. The picture at the top right can be used to objectively document what area of the body the patient's complaint pertains to. This is normally used when there is an injury or skin issue. Going down to the bottom right, we have the assessment or diagnosis section, and then the plan section. Going back up, the note section is a great place to jot down your thoughts or impression, make a differential list, or write a future plan. I normally state why we changed a medication and what I want the team that sees the patient next to do. Lastly, if we look along the very bottom, we have the provider name, volunteer name, room number, and follow-up time listed. It is imperative that these sections are filled out, so please make sure that you do so. Now that we have had time to look at the chart, let's jump back into the SOAP components. First, starting with the subjective section. Again, the subjective section is the patient side of the story, and it provides framework for the objective data to be collected and the context for the assessment and plan. The subjective section is normally written in a narrative form, but sometimes you can see it in a list. It just depends. At Corazon Clinic, we prefer a narrative form, and honestly, that's what you're going to see the most of. I'll discuss a narrative form when I go over an example. One thing I like to remind students of is that being a medical provider is like being an investigator. Your patient has a problem and comes to you to solve that problem. Investigators are curious and are constantly asking questions to narrow down suspects or provide more insight into the case. And that's what you are trying to do here as a medical provider. Probably one of the scariest things when starting out interviewing patients is knowing what questions to ask them, and that's where OLD CARTS comes in. OLD CARTS is an acronym we use as a framework for asking questions about the chief complaint. It's basically a checklist that you can use to make sure you're asking the correct questions. So let's go through what OLD CARTS stands for. First, we have O for onset, or the beginning of when symptoms began. Was the onset traumatic or gradual? If we translate this into a question, it sounds like, when did this start? Did this occur from any trauma? Pretty easy. Second, we have L for location. Where's the location of the symptom? There is a caveat to this, as it doesn't always pertain to everything like hypertension, diabetes, depression, but it's great for injuries, for pain, and skin concerns. Third is D for duration. When these symptoms occur, how long do they last for? C is for character, or what does the symptom feel or look like? Common descriptors are sharp, stabby, dull, achy, etc. Here you can use quotation marks to document what the patient says, as sometimes the descriptions can be a little bit wacky. For example, I've heard some interesting ones like, it feels like my insides are ripping apart like a zipper, or it feels like a tiny 1,000 hammers are beating on my head. So if you encounter an interesting description, just put it in quotation marks. Next, we have A, which can stand for two different things. First, we have associated symptoms, so symptoms that accompany the presenting symptoms, such as numbness or tingling with pain, or nausea or vomiting with abdominal pain, photophobia or phonophobia with headaches. Second, it can also be aggravating or ameliorating factors, also known as modifying factors. These are factors that make the pain better or worse. R is for radiation, such as does the symptom radiate anywhere, and this is most used with pain. T is for timing. Is there a pattern to the pain? Is it cyclical or repetitive, or occur at a certain time of day, like morning or night? Also, is there an event that causes or triggers the problem to occur? For example, burning in the chest after eating spicy food, or knee pain that begins or is worse in the morning. Last is S for severity, and this is not always all that helpful because pain is subjective and experienced differently in all people, but you can use this to track progress. Putting this into a question form, it sounds like, on a scale of 1 to 10, 10 being the worst pain you've ever felt, how would you rate your pain? I usually ask, how would you rate your pain, mild, moderate, or severe? You can ask them either way, it's just based on preference. So that's the OLD CARTS acronym, and again, it's used as a framework for what questions to ask during the patient interview. Now, you do want to be curious, but you also want to ask questions in an efficient way. So be sure that you're asking questions that will provide you with insightful information, that will provide context for the objective section, assessment, and plan. Questions should always be driven by the medical need to know, and it's always okay not to ask all of the elements when pertinent. So this is just a pro tip. Again, OLD CARTS isn't appropriate for every condition. Some of the categories may not correlate with the presenting symptom, such as location for diseases such as hypertension, depression, diabetes. In other words, don't list head for depression or pancreas for diabetes. Just skip it and move on to the next question. If it's not applicable to the presenting complaint, then you don't have to ask it. So now that I explained the acronym, let me go ahead and show you an example. So let's look at an example of the subjective section using the OLD CARTS acronym. Remember that not all the sections are applicable for every patient, so use your judgment. For pain, it's pretty easy to follow OLD CARTS to a T, so that's why I'm using it as an example. Also remember that the HPI is typically written in narrative form. I'm just showing you the list to help you get a sense of what questions to ask. If it's helpful at first, go ahead and write your list on a separate sheet of paper or in the notes section, and then formulate it into a narrative later. I'll show you an example of the narrative on the next slide, and I'll also show you another example when we fill out a practice chart. The more you practice asking questions and writing HPIs, the better you will become, so don't worry too much if it's not perfect. We understand that you're learning and you'll develop these skills over time. So let's go ahead and chart our example. First, we have to document the chief complaint. This is why the patient is coming in. So this patient is coming in for left knee pain, so that will be written at the top for reason for visit. Next, we will move on to O for onset. What led for your pain to happen? Did it happen acutely, with trauma, or gradually? The patient replies, oh, it happened about 2 years ago, pretty gradually, nothing traumatic. So we document that there. Next is L for location. Where is your pain located? Well, it's located on my left knee, kind of in the inner side. So we put the left knee on the medial side. Next we have D for duration. How long does the pain last when it starts hurting? Well, it hurts for several hours after I aggravate it, so pain lasts a couple of hours. Next, C for character. Please describe your pain. What does the pain feel like? It's a dull ache, sometimes sharp, but mostly dull. Next, A for aggravating or ameliorating factors. What makes your pain worse? Standing, walking, taking the stairs. What makes your pain better? Being off my feet and taking some Advil. Next, we have R for radiation. Does your pain radiate anywhere? Sometimes it radiates down the back of my leg into my foot, so we put radiates distally. Next, we have T for timing. Is there a pattern to the pain? Is it constant, cyclical, or does it come and go? It kind of comes and goes, so the pain is intermittent. Lastly, we have S for severity. So on a scale of 1 to 10, 10 being the worst, how would you rate your pain? I would say a 6. So we'd put 6 out of 10, 10 equals worst. Or you can ask, is your pain mild, moderate, or severe? It's moderate, so we can state moderate. Okay, well, I hope that makes sense. Again, practice makes perfect. Let me or your trainer know if you have any questions about old carts. Here is an example of that same HPI in narrative form. A 45-year-old male presents with the chief complaint of left knee pain. The pain began insidiously about 2 years ago and has gradually worsened over time. The patient denies a history of direct trauma to the knee. The primary location of the pain is along the medial side of the knee, occasionally radiating distally to the foot. The pain is dull in character, occasionally sharp. Pain is intermittent, worsen with prolonged standing, walking, and climbing stairs, better with rest and Advil, PRN, or as needed. Patient rates pain as moderate or a 6 out of 10, 10 equals the worst pain. One part of the subjective section we don't spend too much time on in a Corazon clinic is the review of systems, or ROS. The ROS can be applied in several different ways, such as a screening tool asked of every patient, which is what we do at Corazon Clinic. It can also be asked of patients who fall into particular risk categories, or to better define the likely causes of a presenting symptom. For example, patients with the chief complaint of chest pain would be asked a detailed cardiac and pulmonary review of systems. Again, at Corazon, we use the ROS as a screening tool. So upon signing in, the patients are given a sheet with these symptoms on them, and they're asked to circle the symptoms that they are experiencing. Please make sure that you review that sheet before seeing the patient and ask any clarifying questions if needed. Although the list is given to the patient in the waiting area, it is important to ask some of these symptoms during the visit. This is important to assess the stability of the patient, assess the effectiveness of an intervention, or to narrow down your differential. It's also important to ask red flag questions here. Red flag symptoms are the symptoms that are particularly worrisome for a serious illness. Let's go through some of the systems here and what questions to ask. So first we have the general section. Questions that you can ask are about weight loss or gain, fatigue, fevers, chills, or night sweats. Next we have the cardiac section. You can ask about chest pain or pressure, heart palpitations, shortness of breath, lower extremity edema, shortness of breath while laying down, which is called orthopnea, and syncope, which is loss of consciousness or passing out. For the respiratory ROS, you can ask about shortness of breath, cough, chest pain, wheezing, or hemoptysis, which is coughing up blood. Next we have the GI. You can ask about abdominal pain, trouble swallowing, blood in the stool, nausea, vomiting, diarrhea, any kind of changes in stools, or heartburn. We have the psych ROS next, which is memory problems, confusion, anxiety, depressed mood, stress. Next, in the head, ears, eyes, nose, throat, we have changes in vision, ear pain, hearing loss, eye pain, sore throat, sinus pressure. In the genitourinary section, we have burning with urination, also known as dysuria, frequency, urgency, blood in the urine, nighttime urination, also known as nocturia, incontinence, back pain, vaginal discharge. We have neurological symptoms next: numbness, tingling, weakness, dizziness, balance problems, headache, seizures, changes of consciousness or syncope. We have skin next: rashes, growth, hair loss, itching, non-healing sores, lesions that are changing in shape, size, and color. Then we have endocrine, fatigue, weight loss, weight gain, and our 3 Ps for diabetes: polyuria, which is increased urination, polydipsia, which is increased thirst, and polyphagia, which is increased hunger. And then we have the MSK or musculoskeletal section: joint pain, muscle pain, swelling, back pain. This is not an exhaustive list, but just to give you an example of what ROS questions are and what this looks like. One part of the subjective section we don't spend too much time on in Corazon Clinic is the review of systems, or ROS. The ROS can be applied in several different ways, such as a screening tool asked of every patient. It can also be asked only of patients who fall into particular risk categories, or to better define likely causes of a presenting symptom. At Corazon Clinic, we use the ROS as a screening tool. So upon signing in, patients are given a sheet with these symptoms on them, and they're asked to circle the symptoms they are experiencing. Please make sure that you review this sheet before seeing the patient to ask any clarifying questions if needed. Although the list is given to the patient in the waiting area, it is important to ask about some of these symptoms again during the visit, especially the ones that they circled. This is important because it helps you to assess the stability of the patient. It helps assess the effectiveness of an intervention, also to narrow down your differential. The ROS is also important because you can ask red flag questions here. Red flag questions, or red flag symptoms, are symptoms that are particularly worrisome for a particular or serious illness. So now I just want to go through the systems here, and this is not an exhaustive list, but just some questions that you can include in your review of systems. So starting with the general system, we have weight loss, weight gain, fatigue, fevers, chills, night sweats. Next, we have the cardiac section. You can ask about chest pain or pressure, heart palpitations, shortness of breath, lower extremity edema, shortness of breath while lying down. This is called orthopnea, or syncope, which is passing out. Next, we have the respiratory system, which you can ask about shortness of breath, cough, chest pain, wheezing, coughing up blood, also known as hemoptysis. Next, we have the GI or gastrointestinal system. You can ask about abdominal pain, trouble swallowing, pain with swallowing, blood in the stool, nausea, vomiting, blood in that vomit, diarrhea, constipation, any changes in bowel habits, and heartburn. Next, we have psych. You can ask about memory problems, confusion, anxiety, depressed mood, or stress. Then we have the head, eyes, ears, nose, throat section, changes in vision, ear pain, hearing loss, eye pain, sore throat, sinus pressure, postnasal drip. These are all questions that you can ask. Next, on our other column, we have the genitourinary system. You can ask about burning with urination, also known as dysuria. You can ask about frequency, urgency, blood in the urine, nighttime urination, also known as nocturia, incontinence, back pain, vaginal discharge. Next, we have their neuro system. You can ask about numbness, tingling, weakness, dizziness, balance problems, headache, seizures, or changes in consciousness or syncope. Then we have the skin. You can ask about rashes, growth, hair loss, itching, non-healing sores, or changes in lesions, like if they changed in size, shape, or color. Then we have the endocrine system. You can ask about fatigue, weight loss, or weight gain. And then we have our 3 P's of diabetes: polyuria, which is increased urination, polydipsia, which is increased thirst, and polyphagia, which is increased hunger. And then lastly, we have the musculoskeletal system. You can ask about joint pain, muscle pain, swelling, and back pain as well. Again, this list is not exhaustive, and you do not have to ask all of these questions at every visit. That will take a lot of time. You just ask questions that are pertinent to help you narrow down the differential, also ruling out red flag symptoms, and also just helping establish your diagnosis. So here's a list of common conditions that we see at Corazon and the associated review of systems that you would want to ask. So if you have a patient with hypertension, you want to ask them questions about their cardiac system, general questions, and then also the respiratory system. If they present with type 1 or 2 diabetes, it doesn't matter. Ask them about the endocrine review of systems, the cardiac review of systems, along with skin, genitourinary, and neuro. And that's just because people with diabetes are more prone to yeast infections. They can have numbness and tingling. Also, they can have some rashes or poor healing wounds. For back pain, you can ask them the MSK questions, genitourinary questions to differentiate if it's from kidneys or from the musculoskeletal system. You can ask them neuro questions as well as general questions too. And then for asthma, of course, the respiratory system, and then also skin and cardiac. And then for abdominal pain, the gastrointestinal system, endo, general, and also the genitourinary as well. Moving on from the subjective section, we now have the objective section. Here at Corazon Clinic, we are able to take vitals and perform physical exam. However, we don't provide or order labs or imaging. The only type of lab we offer are point-of-care tests, such as a UA or urinalysis and blood glucose testing. So here we're looking at the objective section of our SOAP note. You'll see the body systems listed here. We have general appearance, neuro, GI or gastrointestinal, musculoskeletal, gait posture transfer, which is part of the musculoskeletal exam, HEENT or head, eyes, ears, nose, throat exam, respiratory, cardiovascular or CVS exam, and the skin exam. Of note, at the clinic, we are missing the psych system, but we document psych in the neuro section along with a separate psych evaluation form. I'll go through these systems one by one in another video. After watching that video, you'll be surprised that some of the systems don't really require that much effort, so they're super easy to chart. If you ever need help with performing a physical exam and would like it demonstrated, or if you just want to know how to document your findings, please ask one of our providers. They are here to help you learn and would love to teach you. Now let's move on to the vitals, and remember that vitals are a part of the objective section. The vitals that we gather at clinic are blood pressure. This should always be measured for new patients and for patients with the current or past history of hypertension. We measure blood pressure for every single patient, so this really shouldn't be missed. If their blood pressure is elevated, such as over 150/90, wait 15 minutes and then take it again. If we're using a wrist cuff and it's elevated, also please take it again manually. We also take heart rate, respiratory rate, temperature. Sometimes we take height, but that's not performed very often, and sometimes we take weight, but that is also not performed very often either. And we also take blood glucose. Technically, this is not a vital sign, this is a point of care test, but at Corazon we document it as such. So always measure for new patients and for patients with a current or past history of diabetes. This is very, very important to be able to measure the blood glucose if they have a current or past history. Oftentimes this is missed, so please don't miss it. Also with blood glucose, please indicate if they are fasting or non-fasting. And just a pro tip here, remember to document the blood pressure and blood glucose in the graph section of the chart. Whew, okay, so we made it through the subjective and objective sections, finally. Now on to the assessment part of the chart. Before the assessment can be made, you'll need to present your findings to the provider. We have many providers to choose from, so whoever is available, you can see them. We have a separate video on how to present to a provider, and you'll also learn this in time with practice. The provider is the one that makes the diagnosis, not the student volunteer team. So please don't write things down in the assessment without consulting with the provider first. Again, the assessment documents the diagnosis. A diagnosis is made after analyzing the subjective information and the objective data. Most patients who present to the clinic are following up on already diagnosed condition, but this isn't always the case. So when there's a new chief complaint that presents and you're trying to come up with the diagnosis, go ahead and think of a differential diagnosis, or again, that list of possible diagnoses the patient may be presenting with. Have some ideas in your mind, and if you do and present that to the provider, they may be pretty impressed once you present to them. Once you finish presenting to the provider, they'll let you know what the diagnosis is. Oftentimes, again, the diagnosis has already been made previously and it's just carried on to that next week's chart. For those conditions that require monitoring, like hypertension or diabetes, we have something special to add to the diagnosis. We need to state if their condition is controlled or non-controlled. Controlled means that that condition is stable underneath their current treatment regimen, and we know this by understanding what the guidelines are. So if the patient's objective data, for example, their blood pressure, falls within those guidelines of what it should be, then it's controlled. If it's not, then it's uncontrolled. So again, if the data falls out of those guidelines, it's non-controlled. So for example, the ACC and AHA guidelines state that the blood pressure goal for someone with hypertension is 130/80. So if you have a patient with a history of hypertension and you take their blood pressure and their blood pressure is 148/92, are they controlled or uncontrolled? So in other words, is their blood pressure under 130/80? No, it's not. So even though that they are taking medication, their blood pressure is still high, so their hypertension is uncontrolled. So in the assessment, you would state hypertension uncontrolled. So if they have a history of hypertension and you take their blood pressure and their blood pressure is 126/80, is their blood pressure controlled or uncontrolled? Again, the guidelines say that controlled blood pressure is under 130/80, so they are controlled because they're underneath that number. For diabetes, things can get a little bit trickier, but we considered that diabetes is controlled when someone with diabetes who is on medication presents with a fasting glucose of under 130 or a postprandial or a non-fasting blood glucose under 180. So if a patient that is diabetic who is taking diabetic medication presents with a fasting blood glucose of 120, are they controlled or uncontrolled? Again, we want their fasting number to be under 130, so they would be considered controlled. I hope that makes sense. If not, please feel free to ask one of the trainers, board members, or providers to go over this again. Sometimes it's kind of hard to understand. But anyway, once your assessment has been written down, you can finally move on to the plan. Much like the assessment, the plan is determined by the provider and the provider only, not the student team. The plan is what you're going to do as a result of the diagnosis. And the plan can include many different things, not just the prescription of medications, but it can include the prescriptions of medications, both provided by us or written. It can include a referral to the emergency department or another clinic or provider. It can also include wound care, other dermatological care, injections, counseling, like on diet, smoking cessation, or sleep hygiene. The plan can also be a future plan too, such as continue to monitor blood glucose or blood pressure, and please measure that at the next visit. Again, the plan is anything done as a result of the diagnosis. It doesn't always have to be a medication, although that is the most common. We do provide free medications at the clinic. However, not all of the medications are available, and sometimes we have to write them for them to get filled at the pharmacy. In this case, a written prescription can be made and the provider must write that out for you. If a written prescription is made, please make a copy of that at the printer and scan it and put it in the chart and then hand them the original copy. Same thing with referral. If we refer someone to the emergency department or to another clinic, please make a copy of the referral, hand the original to the patient, and put the copy in the chart. So once that the chart is done, if it needs to go to pharmacy, such as if we are we're prescribing and providing medications to the patient, please bring that chart to Bill for review. He's just going to check over the medications. Once he reviews the chart, he's going to hand it back to you, and then you can take that down to the pharmacy to have it filled. Once the chart is in the pharmacy, you can move on to the next patient. So just go ahead and grab another chart that's placed in the chart rack near the admin staff. If your patient doesn't require any medications from us or really anything, just hand the chart right to the admin board staff member, and they'll take care of it from there. So I want to go over how to write a prescription signature or a prescription sig. This is very important as this is going to be documented in the plan note. This needs to be documented clearly and accurately for the pharmacy and also for the patient. So to write a sig, you need to state the drug name and dose. You can write both the generic name and the brand name. This is also important to do if the patient understands the brand name versus the generic name. For instance, most patients know what Tylenol is, but not always what acetaminophen is, even though that they're the same medication. You want to write out the directions clearly, such as take 1 tablet by mouth twice a day with food, or take 1 tablet by mouth once a day. So make sure that you write them all out clearly. We don't use abbreviations like QD, BID, TID, QID. Here we spell it out completely. So 3 times a day, twice a day, 4 times a day, once a day. I think you get the picture. State what the medication is for. Sometimes the patient doesn't understand. So if it's for hypertension, put high blood pressure. If it's for diabetes, put diabetes. If it's for their joint pain, put pain. Also, it's important to state how long the medication, how long they're supposed to be taking it for, or how many pills to dispense. This is really important when it comes to antibiotics, as those typically have a course associated with them. They could be 3 days, 5 days, 7 days, 10 days, so make sure for antibiotics you state how many days. For other medications, we like to do either week follow-ups or 2-week follow-ups, sometimes a month follow-ups. So we want to make sure that the patient has enough prescription or enough pills for that amount of time. So if you want to follow up with them next week, go ahead and give them 7 days worth. So in the follow-up time, make sure you say 7 days, and then for the prescription, say take 1 tablet by mouth once a day for 7 days. For diabetes. So here's just some examples for you. You can put Crestor or rosuvastatin in parentheses, 40 milligrams. Take 1 capsule by mouth at night for high cholesterol for 2 weeks. Dispense, that's to the pharmacy how many pills to give them, 14. Or albuterol sterets. Drink 1 steret every 4 to 6 hours as needed for shortness of breath or asthma. Dispense 21 sterets. So these are just some examples for you. As you rotate through pharmacy, you'll learn a lot more about this, but if you have any questions about how to write a sig, feel free to ask one of the trainers, board members, or providers. Here are just some pharmacy do's and don'ts for you. Please do write legibly and clearly. Sometimes we can't read people's handwriting and we have to come find you, and that just takes it longer for the medication to be filled. Please always state the drug name and the dose. For example, Prozac or fluoxetine, 10 milligrams. Sometimes the dose is missing and we need to know the dose. Definitely need to know the dose. Again, write out instructions fully. For example, lisinopril, 10 milligrams. Take 1 tablet by mouth once a day for hypertension for 2 weeks. Spell out the instructions fully. Don't do any kind of shorthand. Also specify if the patient is to start a medication, refill a medication or continue a medication. So for example, if it's a new medication like Januvia, you would start Januvia or sitagliptin 100 milligrams, take 1 tablet by mouth once a day for diabetes. Versus if they have the medication already, you just want them to continue it. Continue ibuprofen 200 milligrams, take 2 capsules as needed every 4 to 6 hours for pain. Or if they need a refill Zyrtec or cetirizine 10 milligrams, take 1 tablet by mouth every morning for allergies. If they need a refill, state refill. If they don't need a refill but need to continue it, continue. If they need to start it, start. That helps the pharmacy know what to fill and what not to fill. And if needed, make clear corrections. Just simply cross out the mistake with 1 line. Don't do none of the squiggle business. Just do 1 line just because it gets really crammed in there. And if you start squiggling, it gets really hard to read. So again, don't write in shorthand, no BID, QD, TID, etc. I know that I always get tempted to do it, but please spell it out. And this is because we have different levels of experience in the pharmacy and not everyone is on the same page. Please, again, do not scribble and please write legibly. And please do not forget to specify how long to take the medication. Example, 1 week versus 2 weeks. Alternatively, you can just do how many to dispense, such as dispense 7 tablets, 14 tablets, 21 tablets, etc. So here are just some extra charting tips for you. Again, remember if you need to omit an exam, state detailed exam omitted and then put DEO in parentheses for your first omitted exam, and then for your second or consecutive omitted exams, just put DEO. Never leave an exam blank. Always have something in it. Even if you didn't do it, just put DEO in that area. Do not copy past chart notes. This is how many of the mistakes are made. Now, it is okay to look back on past chart notes, of course, and see what was done and use them for guidance and for reference. But what happens is if a mistake is made in the plan note, oftentimes we see this mistake be carried over week to week. We've seen mistakes with medication dosages, with medication instructions, instructions written completely wrong just because one time in the past it was written wrong. And so when charts are copied and pasted pretty much, that's when mistakes are made. So I always say think for yourself, look up the medication dosages, confirm with your provider that's what the dose should be, confirm with them that's what the sig should be, and try not to just copy and paste directly or copy and write directly from the past plan note to this new plan note. Always ask for help if you need it. We are here to help you. Be sure that medications are filled out entirely and properly. Remember your blood glucose and blood pressure graphs. And please remember to write your name and your provider's name on the chart note. Also, please state a follow-up time in the spot where it says follow-up, and also indicate how many days of medication to dispense. And just remember, practice makes perfect. We all started somewhere. We all started charting sometime in our lives, and this is an exciting time for you to be able to practice this, and this is just the start of your career in the medical field. So have fun, practice as much as you can. It's okay to make mistakes, and of course we are here to help you, and we are so happy that you're here, and we're happy to teach you. So just to give a recap of this presentation, a SOAP note is used to document the patient history. SOAP stands for Subjective, Objective, Assessment, and Plan. All are essential in the medical documentation process. Subjective information is the patient's story, what the patient says. Objective information is what the provider observes or measures through labs or imaging. The assessment is the diagnosis or even the differential diagnosis. And the plan is what is done as a result of the diagnosis or the assessment. And again, it doesn't always have to be a medication. There's many other things in our toolbox that we can use. Try your best. Again, it doesn't have to be perfect, and just be sure to document all of the elements in the chart. Otherwise, if something is missing, we will find you and have it corrected. Thank you so much for your attention in this presentation. If you have any questions, feel free to email us at corazonclinicsa@gmail.com, or if you're at clinic, ask a board member, ask a provider, or a trainer. We are happy to help you. And again, thank you for your attention, and we will see you at clinic.